Well, good morning. Thank you for coming. This is the workshop that we are going to devote to endometrial receptivity, and thank you for being here with us in Valencia. We are going to get started, even if some people they will come later. So if you can close the doors. So as you can see in the program, the idea will be to go with you trying to understand the basics of endometrial receptivity, and then we will focus in the diagnosis of that. In the next presentation, we will have what is the clinical diagnosis of endometrial receptivity with ERA. Then Felipe Vilella will show you what is the next in terms of non-invasive diagnostic test. Then after the coffee break, we will go to the microbiome, and you will understand a new dimension, which is the microbiological dimension that can affect endometrial receptivity. And finally, we will end up showing you what are the clinical research in progress that we have for this. This course is organized, sponsored by Embryonic, so you have to understand this conflict of interest, and in fact, I'm the scientific director of Embryonic. We have products. We work in the translation from the basic to the clinical application. So we are going to have some of the products that you are going to see here. They are going to be used and launched and sold by Embryonic. So you have to understand this as straightforward. But even so, as you may imagine, we really want that things work, and we really want to pass the information, but this is the idea with this workshop. So without further ado, let me just start with very basic concepts about embryonic implantation. As you know, human embryonic implantation is a very inefficient process. And the most important question when the patient failed the cycle is what I did wrong. But they don't do anything wrong. Rather, the system, the process itself is inefficient. And why is that human reproduction is so inefficient? The main reason there are several reasons. But if we just try to go what we know is that, first of all, implantation is not working. So I will go by. Okay. So we have two players here. One is the embryo, the other is the endometrium. Regarding the embryo, human is the only species high percentage of chromosomal abnormalities. So this can explain somehow the efficiency coming from the embryo, because no other species has this percentage of chromosomal abnormalities. But even so, if we just go to a process in which we have a naturally occurring, the natural cycle, the efficiency of embryo implantation, one embryo to implant, is no more than 35%. The most fertile couple needs 4 months to become pregnant. But even if we transfer an euploid embryo correcting this problem, the efficiency is still 52%. And this is in a sunny day. If you compare this with rodents and rabbits, we are still far away from what it could be achievable. Now, why is that? If you think twice, and we have a real expert here on endometrium, which is Hilary Critchley, if you think, and I learned this from her basically, if you think twice, there is a big difference between the mouse and the human. That's why we use studies in mouse, and we extrapolate everything in humans, nothing works basically. The main reason for that is that the difference between mouse and rodents and humans is that in rodents, there is an embryo control of implantation. You have this process called delay implantation, by which an embryo can be floating around for several hours or days until you give the shot of estradiol and they will start to implant. Same happens with marsupials. They have to wait until the conditions, the weather conditions they favor in order to attach, and they float. However, in the human is completely different. The control is only decidual, and this is the mother that controls embryonic implantation, and that's why the reason women menstruate and rodents they don't, neither other main species. So there is a decidual control of invasion and implantation, and that's why, and I'm saying this for about 30 years now, we have to consider the mother and the maternal endometrium, and it's not enough to add progesterone, it's not enough that. So we have to move forward in our knowledge in order to improve this part of the equation to favor what could be the success of the final process. And this is the concept of the endometrial studies, and this is the concept of what we have done so far. Now, endometrial factor is not just a single test, it's not a single concept, it's basically is the endometrial factor, and we have to consider as a broad situation. How can we understand this? Well, it has been trying to be understood since a long time, since more than 70 years. The first work was the work of Noyes and colleague. Noyes just started to understand the histology of the endometrium. At that time, it was a big breakthrough. It was the most quoted papers in obstetrics and gynecology, because it decided how was the luteal phase, and this was a morphological description. Then it came a single molecule approach, the one that was targeted by Bruce Lacey and colleagues, just single specific molecules, and they have some tests in the market about that. Ultrasound is our eyes in the clinic, is our day-to-day. By this, we know whether an endometrium is just a triple layer or is atrophic, and what is the thickness of that. And Doppler has incorporated the blood flow, which is a little bit of health, nothing that is spectacular. And when we run into trouble or we detect some problems at the level of the ultrasound, then we go to the stereoscopy in order to remove if there is any problem, any polyp, any septums, anything that we can do. But this is not a definitive proof that this endometrium is receptive. It's just a proof that there is not a polyp, that the thickness of the endometrium is okay, that there is not a big issue. But again, this that not goes to the end to improve the receptivity or to target receptivity in our patients. Then, since 10 years ago, it was the idea of to use the new technologies, and the one to be used was the transcriptomics. To use a specific gene pattern, a specific gene expression signature to just pinpoint and demonstrate a function. This has been done in oncology for a long time. So it was the idea to come with a endometrial receptivity signature to say, now it shows this signature, this endometrium is receptive, and this was the idea of this. But the transcriptomics moved to secretomics, which is also to find out this information in the endometrial fluid secreted by the endometrium. And the stem cells came to place in regenerative medicine. Now it's in the endometrium and has been used for Asherman syndrome and for atrophic endometrium. We will not touch upon this today. And finally, suddenly we discover that microbes are living in all the organisms in our body, but also in the uterus. The uterus is not a sterile cavity, and the presence of a specific specific pathogens may improve or may alter embryonic implantation. And this is something that we will also discuss here today. So everything must be considered together, and probably new things that will come in the rest of the years to come. But again, this must be considered as a whole. We cannot pretend that with one single molecule, with one single target, we will be able to really have a good diagnosis and a specific diagnosis. Now, the concept that there is a window of opportunity is something that it has been going around, as said, for a long time. We start with the histological criteria of Noyes, but the existence of a window of implantation was already suggested in the 60s, in the 50s by Hertig and Rock. This concept that there is a window there was already demonstrated by David Nabot in the 90s with a specific ovum donation program by which transferring embryos at different stages, at different moments in the recipient, he was able to map the moment that a good blastocyst will never implant, either after the window of implantation or before the window of implantation. This was very nice demonstrated, and you can see the original papers. And finally, Wilcox and colleague, they popularized the concept that the human embryo implants between days 8 to 10 after ovulation. But this work is an England journal, very nicely done. This work was performed using as ovulation identified in the basis of urinary presence of those that are metabolites of progesterone and estradiol. They don't use LH. So they use the urinary metabolite of progesterone. So it's quite an indirect measure. And by doing this, that was the most advanced technology at that time, using radioimmunoanalysis, they basically came with the idea that the embryo implants 8 to 10 days after ovulation. Now, it came, this idea stays, and still nowadays we are under the conviction that the mother is always there for the embryo, that there is a wide time frame that has the same success during these 3 or 4 or 2 days, and this is regardless of whether the patient is different, individual variations, and this is regardless of whether the patient is in the natural cycle or is having a control-stimulated cycle or is having just an HRT cycle. And the only thing that we have done so far is just adding progesterone by different routes, measuring progesterone, and having also the progesterone measure, or just, but we forget about that the target of this is the progesterone receptor. And this is what we are tackling with the diagnosis that we are trying to do. So this will be basically the content. Now, I just mentioned to you about the dating of endometrial biopsy from Noyes et al. But of course, nobody uses histology anymore because we know that this is a high interobserver and cycle-to-cycle variation. And endometrial dating, we know that is not related to the fertility status. So nobody uses this approach anymore. Now, ultrasound, again, as mentioned, this is the information that we can get. But as you will see later on, it doesn't mean that this endometrium will be or will not be receptive, just general patterns of the action of estradiol and progesterone on the endometrial receptivity. Then there are specific tests with specific molecules, which this is the integrity test by Bruce Leslie using alpha-5 beta-3 integrin, or there is another test that it comes from Harvey Kliman from Hale by using these cyclins in the menstrual cycle. Again, this is immunohistochemistry that detects specific molecules and said this endometrium is good or bad, but as far as I know, it's not actionable. That they cannot do anything about that. So, and as mentioned, we have now the possibility to really look for a lot of molecules, many molecules that can regulate a function. And this is why we start to take advantage of the most advanced technology, which was the transcriptomic, that is being used routinely nowadays in oncology. And using this approach, that's why we start, and we, after 10 years of work, we launched this transcriptomic signature of endometrial receptivity, by which we were able to pinpoint this. It's based on 238 genes. It's coupled to a bioinformatic analysis, a classificator, and at the end of the day, by using this transcriptomic signature, the information that we obtain from the samples independently of their morphology aspect is whether the sample will be pre-receptive, receptive, or post-receptive. And by doing this, we are able to go further after the analysis now of thousands of samples. We have not only these three patterns, but also we are able to, within the window of receptivity, we are able to just go to the middle, to the center of optimal receptivity in those patients. So we are able to tune up the signature after proper training, and then we have this type of diagnosis that will let us know for our specific patient whether the window of implantation of our patient is as expected, which is here at 5 days of progesterone, or could be delayed, or could be advanced, or could be more narrow than we thought. So at the end is just trying to map in a personalized matter where the window of implantation is present in this patient that previously has failed implantation. This is how we start to demonstrate this concept, which was basically in patients with implantation failure. And then we came with the idea that if we can detect the personalized window of implantation, we will be able to do a personalized embryo transfer. Keep in mind that personalized medicine is taking over in everything that we are doing. And in fact, we are using this approach for our patients when we have our stimulation, our control ovarian stimulation. So this is just to translate personalized medicine to the moment of the transfer. And by doing that, we are moving for having the embryo transfer always when the embryo is ready, the embryo transfer, to having the embryo transfer done when the endometrium is ready. This is the concept of personalized embryo transfer that could range from 3 days of progesterone to 7 days of progesterone, either endogenous or exogenous. This is the range that we have found that the endometrial receptivity window is. And it could have a real implantation, a good implantation, either here or here, depending on the patient, as you will see in many cases that we have already published, demonstrated, and has been shown by other groups. So this is the idea, this is the concept of that. From case reports to prospective studies, even ending with a randomized clinical trial, has been demonstrated in more than 20 publications from our group and also from independent groups. And I will like just to walk through this to you. We have already analyzed, this was, I think, January last year, we have already analyzed more than 24,000 patients, and the numbers still are similar as we started. In 65 of patients that we do this, the window of implantation is at the place that we believe is, but in 35% of cases, the window of implantation is displaced. The majority of them, they are pre-receptive. They need more days of progesterone. But we have this 12% that they are post-receptive. Again, the concept here is about timing progesterone administration. We understand that there is a priming of estradiol prior to that. Priming can come in a natural cycle or in an HRT cycle. And then it's the moment that the progesterone in the system, the moment that the progesterone receptor is activated, when the whole program started. And this window has to do with this, not with the dosage of progesterone, nor with the route of administration of progesterone, not with but with the timing. And this has been the center of our concept, and by having this done. So this is the idea. When we start with this prospective study in patients with recurrent implantation failure, you can just has been published for a long time, and we really find initially that in 25% of patients with implantation failure, the window is displaced, and by just adapting the window to the patient, then results they go back to normal, and this is for endometrial implantation failure of endometrial origin. So it will account for 1/4 of these cases. This is something that we demonstrated in this prospective trial control. This concept has been already performed from, again, case reports. This is the case of a patient with, for instance, 7 previous failures, 3 ovule donation, and 4 IVF cycles, trying different alternatives with different timings of embryo transfer. And at this time, we just did the ERA test, and the patient was pre-receptive after 5 days of progesterone, and the window was after 7 days of progesterone. Once we transferred the embryo at this moment, the patient became one of twins, and everything was okay. We don't transfer 2 blastocysts, but in this case, there was no way to convince this patient that was 41 to transfer only 1 embryo after 7 previous implantation failure. This has been shown in many cases, even in the American television. There was a patient from New York, I think that she has, 12 failures, and she went to MCBC and present his case. So these are just cases, and in fact, when we start, I just say to my colleagues, just try with your most difficult patient, just try to see in those patients that you don't know what to do, and this is the idea for that. This is just the case of patients with undergoing ovule donation with a very poor implantation rate and pregnancy rate. These were 17 patients collected worldwide, sent in by colleagues worldwide, in which they have altogether in the first and the cumulative very, very bad implantation and pregnancy rate, but always ongoing pregnancy rate was 0%. In the same patient, we did the ERA test, and we find out that in all of them, they have this situation in which they were pre-receptive, 94%, and post-receptive, 6%. And by correcting this in the very same patient doing the personalized embryo transfer, now these patients, they got 34% implantation rate, 50% pregnancy, 66% ongoing pregnancy rate. First attempt, and this was the cumulative pregnancy rate. So this was, again, another thing. What about endometrial thickness? What we have discovered is that, yes, this is the moment that usually we say that the endometrium is receptive, between 6 to 12 millimeters. So in this case, yes, 77% of the patients, they will be receptive at 5 days of progesterone. But even with a very nice endometrial lining, 23% of them, they will not be receptive. This situation, of course, is even worse in atrophic endometrium, but doesn't mean that an endometrium less than 6 millimeters has no receptivity at all. Yes, it has, but you have specific patients that they will have, some that they will not. And also in a hyperplastic endometrium, there will be cases with receptive and without receptive. So we adding another dimension to the general issue of thickness, which, as you know, is a phenotype, is a morphological finding, which is not giving us the functionality of the situation at that moment. And sorry, this is the other thing is how obesity impacts endometrial receptivity. This is a paper that we did in collaboration with Stanford and Baylor. And there is a second paper now coming, by which the question was, what is the percentage of the displacement of the window of implantation BMI increases? So as you can see, indeed, there is an increase of the BMI, an increase of the displacement of the window of implantation that, as you will see later on during the day, can explain somehow the bad or the poor or the suboptimal results in obese patients, especially in morbidity obese, where the window of implantation is clearly displaced in about 50% of the cases. The other thing is, another comment that has been done is that because when you do an endometrial biopsy, you scratch, and then you produce this magical effect that makes possible that the embryo will implant wherever you transfer the embryo. So we went back to our data, and we collect this data for more than 300 patients. And as you can see, the endometrial here, implantation rate and pregnancy rate is exactly the same, whether it was the month after the ERA test, and therefore this small endometrial biopsy, the first, the second, third, fifth, the 5 and 6 months after that. So except if we give to the scratching a magic effect that stays for 6 months, it means that there is no any effect of a mechanical injury after any time. I mean, it's the same clinical effect the first and the 6 months, so it will not be related to this injury effect. And we have also this study done, that this application that we are going to do, which is we have the possibility, because we have, as you have seen, thousands of cycles done. So we have the possibility to say, okay, even if we let you know that the endometrium is non-receptive, if you have transferred this, if you have done this and wanted for us results, let us know about that. So we were able to collect 52 patients that having a non-receptive endometrium, the transfer was done at the time that was non-receptive. And the side to side, we have this one. The patients by which the transfer was done according to the recommendation of the ERA test. And by doing this exercise, we have in those 52 patients, again, a very bad implantation and pregnancy rates, 13%, 23% in the first attempt, but 0 ongoing. Whereas our patients, the patients that they were following the recommendations, they have 45%, 60%, and 74%. Of ongoing pregnancy rate. This is another demonstration. This comes from a group in Canada. This is an external study. The clinic, I think the name is Olive. It was just recently published. And what they did is, if this really can add something about the endometrial factor, let's check what happens when we have a recurrent implantation failure of euploid versus a standard transfer. The euploid embryos transfer either following ERA or without ERA. So now this is a transfer of chromosomally normal embryos, in which this is the implantation rate when they have with a standard embryo transfer, and this is just by correcting the endometrial factor in this patient. This is the implantation rate. This is the ongoing pregnancy rate, which is basically 20% higher, and this is the live birth rate of having, this is endometrial factor plus embryonic factor corrected versus only embryonic factor corrected. As you see, the P was not significant. This was a retrospective study. They have these 70 or 80 patients. This was me just to check this in principle. You have to know that this is not insignificant, but this was the difference that they found in this study. And this is just, we have collect data for different clinics. You have here the name of the clinics. This was just gathered by Maria just this week, just to show you this. And about 500 patients here, in which we have the results in which the personalized embryo transfer was done at the first test or after the correction of the window of implantation. And as you see here, the results that we obtained was, this is the number of patients. The implantation rate was was quite similar in those that we transferred at progesterone plus 5 at the first or after the correction of the window of implantation. So it was the pregnancy rate and all the parameters was similar, and ongoing pregnancy and ongoing per embryo transfer was also similar. So this is somehow showing you that those patients, again, these were patients with implantation failure. So those patients that we correct in the window of implantation, we basically equalize the results to the patients that they were having the implantation at the moment that we expected. So this is another proof of concept. And this is when we analyze patients with their using ovum donation and their own oocytes, whether they were chromosomically analyzed or not, showing you what is the dimension that we can add if we correct the endometrial factor on top of the embryonic factor here. So as you can see, implantation rate, when we use their own oocytes here, we have this 62% and 46%. This is 20% when we work with embryos chromosomally normal or not analyzed, but with the endometrial factor corrected, as you can see here. And similar features for pregnancy rate and biochemical and ongoing. So this is what we can add up with the endometrial factor corrected. But I guess the final proof of concept has been, or it is, to show this in a randomized manner. So we undertake this study, which is a prospective randomized multicenter clinical trial. We started in 2013. This was the number of patients that has to be recruited, 546 patients. These were the inclusion criteria. As you can see, there are normal patients, less than 37-year-old, normal BMI, normal ovarian reserve. PGS was not an inclusion, neither an exclusion criteria. And with that, we just move forward. We collect, this was the design by which once patients with this criteria, they were recruited, we divide them and they go blastocyst transfer in a fresh embryo transfer. I know that terminology in the United States is different, but this is fresh embryo transfer, deferred embryo transfer, or personalized embryo transfer. So these are the three arms of the study. And by using these were the centers that they were involved in the study. And we opened the label at the interim when we have these 356 patients. It was in April 2016. The trial started in 13. Interim was evaluated in 2016, and the study finished last year. And we are just waiting for the final deliveries of the babies that will be done the next months. But this was the interim study that we presented in ISRM, and this was the results. So you see that this is the pregnancy rate in fresh, all frozen, and personalized embryo transfer. So there was a 25% increase in the personalized embryo transfer due to the endometrial factor. This was significant. Whereas implantation rate, even if it was increased, it was not significant at that time. Biochemical, ectopic, and clinical miscarriage were the same. Ongoing, you have this 10% increase or more in when you correct the endometrial factor, but was significant at that point. And twins and singletons, it was an effect that we have here. Basically, we have less twins and more singletons in the personalized embryo transfer compared to the other groups, although it was not significant at that moment. So the conclusions that this personalized embryo transfer guided by ERA is associated to a significant improvement in reproductive outcomes in this interim study, and we are waiting to the publication of the final data. Recurrent implantation failure is the main indication to understand where is the window of implantation for those patients nowadays. This is our main purpose. It has been demonstrated. Now, whether we can move to the first appointment, we can move to every patient, this will be demonstrated, if so, by the randomized clinical trial once we publish the final results. So I just want you to understand that this is just, as you want to start with something, you have to do it in the worst scenario, as we do in cancer. So we start with recurrent implantation failure. We will see whether this could be the case also for the first appointment. And the point that I want to make that I see is about synchronization, and this is a concept that is quite important. And in order to have this synchronization, we have to know in which stage is the embryo and also to couple the stage of the endometrium by having this. We have some very interesting data, and now we have one generation of babies born with ERA test. After 4 years, the patient come and we do the transfer at the same time that it was done 4 years ago, and they became pregnant again. So many data, not only this, but also published this, we follow up this up to 4 years, suggests clearly that the window of implantation, as any other function in our body, remains the same throughout your life. But remember that the endometrium is a hormonally regulated organ. So if you give different type of hormones, different dosage, results cannot be the same. Just keep this in mind. And also, I have remember that in IVF, what we have is that the embryo is just fixed in one moment of the development because we freeze them, and then we have the endometrium, which is what we have to synchronize with the embryo. You can have perfectly a normal pregnancy and having a displaced window of implantation. And I learned that from a colleague in San Diego, that he has a series of about 50 patients in which those were secondary infertility with a child, and then she did that. In fact, he told me, do I have to do an ERA test if I have a baby already? And I said, no, if you have already a baby, say, well, we have found this. Because in a normal pregnancy, both the embryo and the endometrium, they have their own speed. And you can find a fast embryo with a fast endometrium, or a slower embryo with, but it's fixed one of them. So once it's fixed, day 5 or day 6 is the same, because you freeze them at the moment that you think is viable, and then you have to couple the endometrium to that. So keep this in mind. These are things that that we have learned through these 5-6 years we start to launch this. And I just want to acknowledge that this is the work of a team that is directed by Maria Ruiz, which is the next speaker now, that is going to let you know about the practical issues of ERA. And also the team that working in the lab. This has been growing a lot. And also it's possible because the work of Diana, that is taking care of the project managing and having all the studies controlled. Carlos, which is the soul of the program, going from one center to the other in the world, being sure that the clinical studies are being done properly, that everybody complies with the regulations, that this is started. And David Blesa, that start with this project, with this idea, and most of the main changes that we performed from the beginning was due to him. And also, again, as mentioned, we are now a big bunch of people working worldwide, trying to have these projects and these products just used in everybody of the world that can have access to. And this is, and I have many people working in research and also in the regulation of all of these techniques and tests. Thank you very much for your attention, and I'm just open for any questions that you might have.
Good morning to all. Thanks Carlos for the presentation. My name is Maria Ruiz. I am Good morning to all. Thanks Carlos for the presentation. My name is Maria Ruiz. I am the ERA Clinical Manager of Genomics, and mainly I am answering questions from clinicians and patients regarding the endometrial receptivity analysis. And I would like to show you today the main considerations to have in account when performing the ERA test. Okay, as Carlos has commented to you before, the ERA test was patented in 2009 after 10 years of research on endometrial receptivity. Originally, it was based on microarray technologies, but from January of 2017, we changed to NGS. Now we are sequencing by sequencing the expression in expression level of 256 genes, and this is coupled to a computational predictor, which is going to tell us the specific transcriptomic profile for an endometrial biopsy. As you already know, in a menstrual cycle, an endometrial cycle, women are producing estrogen and progesterone in order to prepare the endometrium for the implantation. The same happens for an HRT cycle, but in this case, estrogen and progesterone are administered in an exogenous way. I would like to talk referring to HRT cycle because, as Carlos said, this is the type of cycle in which we can control the specific time with progesterone exposure for the endometrium. So it is better in order to control and to replicate for the transfer cycle from the result obtained in the ERA biopsy. So usually for most of women, the window of implantation opens once they have been with 5 full days of progesterone administration. This is at progesterone plus 5. So if we take an endometrial biopsy at that moment, we will find a receptive result. However, in some cases, for a percentage of patients, they need more time with progesterone administration to reach receptivity. Therefore, if we have a progesterone plus 5, we will see a pre-receptive result. On the other hand, we have the opposite, that this patient that need less time with progesterone, they have an advanced body. So if we have a standard progesterone plus 5, we will see post-receptivity. If we focus on the secretory phase, we can subdivide it in pre-receptive, receptive, and post-receptive. These stages are not fixed, so we are going to find variation according to the specific moment in which we find the endometrium. I mean, for example, for the pre-receptive stage, we can find an endometrial biopsy taken at progesterone plus transcriptomic profile is far from receptivity. Therefore, in these cases, the patient will need 2 more days with progesterone to reach receptivity. But then we can find patient with sample taken at progesterone plus 5 has a pre-receptive profile, but closer to the receptive state. So these patients will need just 1 more day with progesterone to reach receptivity. For the post-receptive stage, happens the same. We can find profiles close to receptivity, yet just need 1 day less with progesterone to reach receptivity. According to that, if we go to what will be the classical decision tree to be applied in the clinic, we will have that, first of all, we always are going to take the biopsy in the standard moment for receptivity for most of the patients, which will be in HRT cycle at progesterone plus 5. Once we have the biopsy analyzed, we can find 4 main results, which will be receptive, pre-receptive, needing just 1 more day with progesterone, pre-receptive, needing 2 more days with progesterone, or post-receptive, needing either 1 or 2 days less with progesterone. For the 2 first cases, receptive and pre-receptive, needing 1 more day, we are going to give you a direct recommendation for the personalized embryo transfer in the subsequent cycle, just following the recommendation given in the report, which will be for pre-receptive, just add 1 extra days of progesterone, and for receptive, we could have or early receptive, late receptive, or just receptive. So we will give you a recommendation up to add the rest 12 hours with progesterone, or just to replicate the same that you did for the endometrial biopsy. These 2 possible results correspond to the 90% of samples that we are receiving. Okay, and for the other 2 cases, then it will be required a new biopsy in the specific date recommended in the report in order to validate the predicted window of implantation. This is because in these cases, in the case of pre-receptivity needing 2 more days, the transcriptomic profile that we have analyzed is far from receptivity. So we need to check that the recommendation of 2 days is correct, because sometimes this is due to an endometrium that answers in a slow way. So sometimes these 2 days are not enough to reach receptivity. For that, we recommend the validation with the biopsy. And for the post-receptive cases, what we have found is that in the post-receptivity at progesterone plus 5 used to be correlated with patients with a very narrow window of implantation with less of 24 hours of length. So in this case, 1 day less could mean that at progesterone plus 4, the patient will be pro-receptive. So the recommendation will be to transfer between both biopsies. For that, again, we need this new biopsy. But these cases just suppose the 10% of cases that we receive in the laboratory. So these are the data updated through the last week. We have now more than 32,000 patients analyzed from 2010, in which we started to offer this test at clinical level, and we have working in more than 60 countries and with more than 1,000 clinics. If we focus just on those samples that we have received at progesterone plus 5 and analyzed it by NGS, we have that 66% of samples were receptive, 29% of them non-receptive, pre or post, and in 5% of cases we have not a valid diagnosis. For this percentage, 5%, we are not going to charge nothing for the test, and in the next slides we will review the main causes for this, okay? If we focus just on the non-receptive cases, you can see that the most of them, 89%, result pro-receptive. This is women that has a delayed window of implantation. Then we have a 10.5% of cases of poor receptive result and just 0.5% of proliferative result. But in this case, proliferative used to be related to mistakes in the protocol of the preparation of the endometrium. For example, that the patient has been properly the progesterone, or that the LH surge in the case of a natural cycle has not been detected properly, because it is so rare to find an endometrium proliferative after 5 full days of progesterone properly administered. So most of cases is due to a mistake in the protocol. And inside of these 89% of pre-receptive cases, most of them, more than 95%, are going to need just 1 more day with progesterone. So these will be those cases in which, even being non-receptive, pre-receptive, we are going to recommend to you in the first biopsy just the day for the personalized embryo transfer. For those cases in which a second biopsy was performed, we find that almost in 93% of them, with this second biopsy, we get a recommendation for the personalized embryo transfer. And just as 7% will require a third biopsy. This will be the cases in which I have mentioned it to you before, in which maybe the 2 days recommendation has been not enough and the patient keep being pro-receptive. Well, there are several factors that could affect the endometrial receptivity, and I want to focus on that you have to take in account previous to take an endometrial biopsy for analyze the receptivity of your patients. First of all, we need to be consistent between endometrial biopsy cycle and transfer cycle in order to be able to reproduce the result. Okay, we made some years ago a pilot study with just 5 patients in which we take 4 samples for each patient in different months and in different types of cycle. Natural cycle based on LH surge, natural cycle based on HCG triggering, HRT cycle, and stimulated cycle. And we see that not all the patients answer in the same way. So there are patients that could answer in different way to endogenous progesterone than to exogenous progesterone. For that reason, we recommend that if you are performing the biopsy in HRT cycle, you have to do the transfer in the same conditions with the same protocol. Or if you are doing the biopsy in natural cycle, then replicate the transfer at natural cycle. As Carlos has shown you earlier, also we have the question about if the biopsy is affecting the transcriptomic of the endometrium. So as he has shown to you, there are no difference in the pregnancy rate and implantation rate regarding the month in which the transfer was performed after the ERA. But also we have a study in which a patient has 2 consecutive biopsies on the same cycle, one at progesterone plus 5 resulting receptive, and 2 days apart at progesterone plus 7 resulting post-receptive. And we compared this last biopsy with biopsies from women having just one biopsy at progesterone plus 7 and being post-receptive, and there were no transcriptomical difference between these two biopsies. So the first biopsy at progesterone plus 5 made just 2 days earlier has not affected the transcriptomic profile of the endometrium. Also, we have the issue about the endometrial thickness. We have several questions from doctors talking us about the patients with atrophic endometrium and if they can do the ERA test on them. Yes, the ERA test can be done in a patient with an atrophic endometrium with an endometrial thickness below 6 millimeters. The only issue that you have to take in account is that for this kind of patients, you will have a higher risk to have a displacement of the body. But in this patient, we are going to find the window of implantation moment and recommending the personalized embryo transfer accordingly. But you have to be sure that your patient has an atrophic endometrium consistently for all the cycle. For example, you have a patient that has good endometrial lining for their cycle, one cycle in which the endometrium has not grown, then you have to cancel the cycle. But if you have a patient that never reached more than 6 millimeters, then you can perform the ERA as usual without problem. On the other hand, we have the endometriosis, if it is affect or not to endometrial receptivity. There are controversies regarding this, but regarding the ERA, the specific genes, what we are analyzing with the ERA, we have not seen difference between different stages of endometriosis. We published this study in which it was comparing in the AMP4 versus control, patients without endometriosis. And we see, you can see here in this unsupervised hierarchical clustering, that patient didn't group regarding the stage of the endometriosis, but they group regarding the day in which the endobiopsy was taken. I mean, if they were pro-receptive or receptive. In green, you can see the samples that were taken at day 19, 20 of the cycle, while in orange, there is the patient in which the sample was taken in day 18. So you can see that they group better regarding this green and orange than with the all other colors that are related to the endometriosis stage. Also, you can see here, in which in the first PCA, we can see the samples with color according with the endometriosis stage, and there is not a visible group for any of them. But if we see the samples here, in which green again is samples taken at 19 and 20 days, and samples at orange are taken at day 18 of the cycle, we see that the samples group according with the day in which they were taken. So based on these results, the ERA won't be affected if your patient has endometriosis or not. So you can either make the test for this kind of patients. Well, when to perform the ERA test? It can be done in natural cycle or in HRT cycle. As you know, we prefer HRT cycle because it's a better way in which you can control perfectly the specific time in which your patient has been exposed to progesterone, and it is better in order to replicate it in the transfer cycle. But if you have patients that are going to have the transfer in natural cycle, you can do the ERA also in natural cycle. You can do based on LH search, then you have to take the biopsy at H+7, or with HCG triggering, then you have to take the biopsy at HCG+7. In the case of HRT cycle, our standard protocol is to start with estradiol from the first or second day of the menstrual cycle, and then 7 or 10 days after that, you have to check the endometrium with an ultrasound to check that this is triple layer, more than 6 millimeters, and then you have to, this is mandatory, to check the endogenous progesterone at blood, and you have to be sure that this is less than 1 nanogram per milliliter. If everything is okay, then you can start with the progesterone administration, which will be for 5 full days. This is 120 hours after the first intake, okay, and then to take the endometrial biopsy. The endometrial biopsy is taken from the fundus of the uterus with a Pipel catheter. We have also a specific protocol in case of stenoic cervix, or any case that you find a complication. For example, if you have a patient with a bicornuate uterus, we are going to give you also some specific recommendation. So, but basically, this is taken from the fundus of the uterus. You have to take at least a piece of tissue of 5 millimeters. This is a very small piece of tissue tissue what we need to analyze, but we have a limit in the maximum. We have, this is the cryotube that we are supplying with the kit, and there is a line in the bottom of the tube, white line, and you cannot put more quantity of sample than this line, because this tube is with a preservative inside, which is going to preserve the sample, and if you put more quantity of sample, the liquid won't be enough to preserve properly the sample, okay? Also, you have to be sure that the sample is not blood and mucus, because if there are no tissue, for sure to be able to analyze it, and for that, once you put the endometrial tissue, the endometrial sample in the tube, you have to shake it and to be sure that you are able to see some piece of tissue. Then you have to keep the sample in the tube immediately after taking it in a refrigerator at 4 degrees, more or less, during 4 hours. This is necessary in order that the liquid, the preservative liquid, go inside the tissue to preserve properly the RNA, which is what we are going to analyze. Once these 4 hours has passed, then you can send the sample at room temperature, but always this room temperature has not to be over 35 degrees. Because if not, the liquid, the preservative liquid will not work properly, and then the sample will be degraded. To which type of patients you can do the ERA test, you are seeing that now we are working with the randomized trial to see if it is a benefit if we use the ERA test in the first visit clinic, but for now we are offering it to patients with recurrent implantation failure. After more than the 32,000 patients that we have analyzed, we are considering as implantation failure when the patient has 2 or more implantation failure with their own oocytes, or 1 ovum donation failure, okay, and always with good quality embryos. In those cases, you can just recommend the ERA. Also, we need to do the biopsy on a morphological normal endometrium. This is if you have an endometrium in which you have to do a surgical intervention prior to the transfer, then you have also to do this surgical intervention prior to perform the biopsy. Okay, so for example, if you have a septum or whatever, you do the surgical intervention and then biopsy and then the transfer. Okay. Also, as I have commented before, you can also do the biopsy on atrophic endometriums. Once we receive the sample in our laboratory, more or less in 10 days, you will receive the result. Usually it used to be less than 10 days, but our deadline is 10 days. So you will receive this kind of report in which you will have information about your patient, the clinic, and the sample, and the diagnosis, a recommendation, and a brief summary about the interpretation of the result. We are going to spy you here if you are recommended to do the personalized embryo transfer and at what specific moment, or if you need a new biopsy. Well, we are going to see some kind of examples regarding the result that you can get. So we have a first cycle, HRT cycle, in which you have taken the endometrial biopsy at progesterone +5. Then, once you take the biopsy, you remove the hormones to the patient, then she will start to bleed, and then you can start immediately the new cycle. 7 days later or 10 days later, you will receive the report, and if in the case that this is receptive, you will continue with the progesterone administration and then perform the personalized embryo transfer in the same moment in which you take the biopsy. But if the result that you receive is pre-receptive, needing 1 more day, then you will replicate the same done for the biopsy, but adding this 1 extra day with progesterone. In the other hand, if you have a post-receptive result, you will need to repeat the biopsy, but 1 day earlier regarding the moment in which you collected the first endometrial biopsy. Once you have the result, your recommendation for the personalized embryo transfer, we have a kind of calculator in this link in which that you can use to calculate the moment in which your patient has to start the progesterone. Okay, so I'm going to show you a brief example about how to use it. You will find here that you have to select, I don't know if, okay, and you have to select the type of cycle in which you are going to perform the transfer, which could be HRT or age-triggering natural cycle. For example, if we select HRT, Then we will have this, and we will have to choose if we have a blastocyst transfer or a day 3 embryo transfer. This is because if we are going to transfer a blastocyst, we always are going to do it on the day in which we found receptivity. But if we have a day 3 embryo transfer, we have to do it 2 days earlier, because the day 3 embryo transfer, the day 3 embryo needs still 2 more days developing inside of the uterus to reach the blastocyst stage, and we have to match receptivity with blastocyst. Okay. Also, you have to select to put here the total number of hours with progesterone for the transfer that had been indicated in the report, or if you don't have the number of hours, the number of days, P+5, P+4, P+6, and also you will put here the date and the time in which you are supposed to do embryo transfer. Then if we do all of this, you can see here that we have selected blastocyst, 120 hours for the transfer, and that we want to do the transfer on 20th of April at 10 a.m. Then we will click calculate, and we will have that the patient has to start with progesterone day 15 of April at 10 a.m. We have, you can see here that we have a range of +less 3 hours. This is because when we give you a transcriptomic profile for your sample, we have this time frame of +less 3 hours in which this transcriptomic profile is not going to change. So you have a time frame in which, if, for example, you have an unexpected delay on your transfer time, or you have to advance it, there is no problem, because you have a time frame of 6 hours in which you can do the transfer. Okay. This is very useful also for cases in which we have found early receptivity or late receptivity. Those cases means that the patient are in transition between pre-receptivity and receptivity, or between post-receptivity and receptivity. And in those cases, we are going to recommend to you to add or to rest 12 hours. To calculate this used to be more complicated, so it will be very useful for you. These are the cases in which we are not getting a valid diagnostic. As I have told you, we are not charging nothing for these cases, but a new biopsy will be required in order to get a proper diagnosis. The percentage that we have for any of the cases is 2% of cases in which the RNA is not valid because it is degraded. It could happen because, for example, during the shipment, the temperature has reached more than 35 degrees, and then the RNA has been degraded. Or also can happen because the sample in the tube is too big, more than the white line indicated in the bottom of the tube, so the liquid preservative liquid has not been enough to preserve properly the whole sample. Or because there are a proper quantity of tissue, but too much blood and mucus, making that the total volume of the sample is too big. Another 2% of cases that we receive in which we have not enough RNA. We need really a very few amount of RNA to analyze by NGS, but sometimes we find that the endometrial tissue is almost nothing, it's a very, very small piece of tissue, and it is not possible to extract nothing, or that all the sample is mucus or blood, that is not possible to extract RNA from there. And also we have a few percentages, now it's a bit less than 1%, in which we have a non-informative result. This is like a chaotic profile. This is samples that apparently are good, are fine in size, and the RNA is not degraded, but our predictor is not able to associate this transcriptomic profile with our control profiles. Usually in most of the cases, when you perform a new biopsy, it is solved, and then we have a proper diagnosis, because this is due to some intrinsic characteristic of the sample. But we have like 1 or 2 cases in which the patient keep being non-informative despite several biopsies, and this could be related to a specific issue in the endometrium of the patient. But as I have told you, we have just 1 or 2 cases from 32,000, so this is not common. This is the case report that Carlos has presented, and I just want to show you again, because this is the classical patient that we can find with an ERA test. That is patient that has several failures now. Luckily, we know that we have not made so many cycles, not 7 cycles, to perform the ERA. Okay, you with 1 or 2 cycles in which the patient has failed, then you have the ERA. But this is a classical patient in which everything has been tried, and then no pregnancy, but you perform the ERA, it was pre-receptive at progesterone plus 5 and receptive at progesterone plus 7. However, we are not offering you just a report with the recommendation for the transfer, but we are also offering you a clinical follow-up with your patient and a specific deal with your clinic, in which if you want to collaborate, we will send to you a table with your cases, for example, for 2017 or for the specific period that you prefer. And then we are going to request to you some information about number of transferred cycle, if it was ovum donation or own site, number of implanted sacs. And with that information, we are going to prepare to you this ERA clinical report, in which we are going to show you your specific rates for your patients, also for receptivity and non-receptivity, and for the clinical outcome, and compare it with the global ERA data, the data that we receive from all the clinics over the world. So you can see if your receptive rate is higher, lower, and we can detect some issues maybe when taking the sample, or maybe with the protocol for preparation when preparing the endometrium. And also you can see if your rates of pregnancy or miscarriage are higher or lower than the global, and also we can find some issues that could help you in the management of your patients. Well, this is the ERA team. Also here we miss the bioinformatics team, which helps and works with us very close, because the ERA need a highly support from the bioinformatics team. And as Carlos told, we are growing, and there is more people that is not here that is working hard with ERA, because now we are analyzing more or less 1,800 samples per month. We started in 2010 with just 8 samples per month, and now we have 1,800. So we need to grow. And this is the global genomics team. And in case that you want, you have any doubt regarding the ERA test, you can, if it is more a logistic issue or to request a kit, you can write directly to support@genomics.com, or well, it will be specific according with the country in which you are. And if you have clinical or technical questions, you can write to our email at era@genomics.com or maria.ruiz@genomics.com. And for sure, if you have now any question or you need any clarification regarding all of this, just. Well, I don't know if you can hear me. Hello, can you hear me? Hello? I don't know if you can hear us. You? Hello? 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 Hello.
Can you hear us? Sorry. Can you hear us?
Hello?
¿Quieres ir contestando las preguntas? Viendo las que estamos aquí ahora, hemos terminado los vídeos, pero parece ser que no nos están oyendo. A ver si puedes bajar. No, y eso que están verde los dos cositos. Eso. Vale, vale. ¿O nos oyen o no les oímos nosotros? No lo sé.
No, que yo no veo las preguntas.
Okay, so you can hear us. Okay, we are not able to hear you.
Not hearing you.
Yes. So then, if you hear us, we will answer in the questions. Okay. Just with voice. Please, if you have any problem,
We can start answering the question that the people were doing by writing at the beginning, and then when we are doing some fix to solve the problem that because we are not hearing you. Ellos sí nos oyen, pero nosotros a ellos no. To go ahead with the oral asking. So at the beginning, we will start with solving the writing question if you prefer.
Hello?
Estaba en Bluetooth. No estaban oyendo nada.
Sí, sí, nos han dicho que sí que nos oyen.
Antes sí nos oían, ahora ya no.
Hello, can you hear us?
Sí, pero ellos nos oyen.
Hello?
Ellos nos oyen, pero nosotros a ellos. Me ha escrito Rayín con el WhatsApp. Me ha dicho que sí. I can hear both of you.
Okay.
Okay, we cannot hear you, but we will answer in the questions. Okay.
But the writing first.
Yeah.
Pero si ellos no nos oyen a nosotros, el problema lo tienen ellos entonces.
No, ellos sí nos oyen.
Quiero decir,
Nosotros no
pero nosotros no los oímos a ellos porque a lo mejor su micro o algo no
No lo
está
tienen
activado. Que revisen esto porque nosotros es que no tenemos más, nosotros decimos
Sí,
audio.
las que se escriban por ahí, ya está.
Sí.
Sí, es que aquí no hay más opciones realmente. Quiero decir, nosotros no configuramos, ya he visto que el audio sí que funciona, que estaba mal puesto.
Okay. We're going in the order with the question.
Sí,
okay. Okay.
Okay, so the first question is that want to ask the practical application of error results. How will you implement the displacement suggested? Well, when you collect an endometrial biopsy to analyze with ERA, you will receive a report in which we are going to tell to you if the window of implantation is displaced or not. If it is not displaced, then we are going to recommend to transfer a blastocyst in the same date of cycle and day of cycle in which you took the biopsy. However, if we find a displacement of the WOI, then we are going to recommend to perform the transfer following this displacement. I mean, if you take the sample at progesterone +5, but we find that the window of implantation is displaced and that this endometrium is receptive at progesterone +6, then you have to transfer the blastocyst as progesterone +6. Dr. Murdia, I don't know if you can let us know if the question is answered and we can pass to the next question. We don't hear you, so we need that you write on the table. Okay. Were there any difference in Indian and Spanish women in terms of genes analyzed? Not. We analyze the same genes for all the population in the world. There is no difference for population, neither based on the origin of the patient.
In addition, we don't have any differences between different ethnicities.
Okay, the next question is the report of ERA is valid for how many months if the patient wants to take the embryo transfer for other reasons? Well, the consistency of the ERA result has been proven up to 3 years. The only issue is that you have to take in account that, as you have seen in the video, the body mass index can affect the ERA result. So just in case that there is a big change on the body mass index, then you will need to repeat the ERA. But if there is no change on the body mass index and also the patient has not any relevant surgical intervention, neither treatment, hard treatment like chemotherapy or something like that, the result will be consistent for up to 3 years. How much progesterone was routinely administered to patients during the evaluative cycle? Well, in our standard HRT cycle, we recommend 800 milligrams of progesterone, vaginal progesterone.
By day.
Yes, which is administered as 400 milligrams each 12 hours. But this is our standard protocol for HRT. You can use your routine protocol for HRT in your clinic if you want. The main important consideration is that you have to replicate the HRT protocol for the biopsy cycle and for the transfer cycle. Is there any difference between the duration of validity of microarray era and NGS era? Yes, there is no difference between microarray and NGS. The test is the same, we just changed the technology and we improved the predictor, so now the prediction is more accuracy. But there is no difference on the duration of validity. I don't know if there is more questions there.
No,
we cannot hear you, Dr. Murria. Okay. Does given sildenafil or heparin affect error results?
We don't have enough data to know if it's affected or not, but we prefer don't do any treatment besides the ERA during the cycle. And if you add any treatment during the ERA cycle and you have the receptive results, you have to take in account to use the same treatment and the same doses during the transfer cycle also.
Yeah, have you heard the answer from Diana? Did you hear the answer to this question from Diana?
Sorry. The thing is to know that any treatment that you do in the ERA cycle, you must repeat the same doses and treatment in the embryo transfer when the ERA results is receptive. We don't have any data about heparin or sildenafil, but we don't have any data related to these or other treatments. But when we have the receptive results during the ERA, it's better to do the same treatment in the embryo transfer cycle.
Okay, if the result is pre-receptive, there are two options. One is that the endometrium needs 1 more day with progesterone, and the other option is that the endometrium needs 2 more days with progesterone. In case that the endometrium just needs 1 more day with progesterone, then you will be recommended to perform the embryo transfer without to perform a new biopsy, but following the recommendation about to add 1 more day. For example, if your patient is pre-receptive at progesterone plus 5, and the recommendation is that needs 1 more day with progesterone, then you will have to transfer the blastocyst at progesterone plus 6. In the other hand, if your patient results pre-receptive but needs 2 more days with progesterone, then as this endometrial profile is far from receptivity, we will need a second endometrial biopsy to validate the predicted window of implantation. In case that your patient results post-receptive and needs 1 or 2 days less with progesterone, in any case, we are going to need a second endometrial biopsy to validate the window of implantation. Summarizing, just the cases in which a second endometrial biopsy is needed is just 10% of samples that we receive. Since the pre-receptive samples needing 2 more days with progesterone or the post-receptive samples are just the 10% of cases that we are receiving. So in most of you are going to receive directly the recommendation for the blastocyst transfer. If you have more questions there.
Wherever, when you have any doubt and you want to ask to us, we can you can call us or you can mail to us just to answer question the answer, and we will answer the question that you did. For instance, if you have any pre-receptive patient, we can calculate the right time to do the embryo transfer. It's important to take in account the embryo stage also. We are always talking about the blastocyst stage. So if you want to transfer a 2-day embryo or a 3-day embryo, you must think that those embryos will be transferred with 48 or 72 hours of differences. So the thing to take in account is the blastocyst stage. So if you have a receptive era, you have to transfer the blastocyst stage in a P+5 day. But if you have a day 3 embryo, you have to do the transfer in a P+3, because the embryo will get the blastocyst stage 2 days after. And the progesterone, the pregnant progesterone in the patient will be 2 days after also. I don't understand what is PRP, please. Will the progesterone. We don't have any data about this therapy. I think that is the same that we advertise with other kind of therapies or treatments. It's just to repeat the same procedure in the ERA cycle as the embryo transfer cycle. But because this therapy maybe is just one therapy in the time, it's better to wait at least 2 or 3 months after do it, because maybe this kind of therapy affect the ERA results. If you will repeat the therapy for a long time, you can do the ERA cycle and the embryo transfer during the therapy. But if you think that just one time this therapy, it's better to go far away from this therapy.
Am I audible?
Oh, now we can hear you.
Yeah,
But not
yeah.
you.
There was some problem with the mic. Now it's okay. I think we don't have any more questions. If there are any more questions, we can interact with you on the email ID if you can provide some.
We can
I'll finish it.
hear well.
We'll go to the local office from here in India. Hello.
Hello?
Hello?
Yeah, yeah. Thank you so much, then Dr. Maria and Dr. Diana. Thank you so much for the interactive webinar on ERA. It would definitely have an impact on our clinical practice, and we can work around things for testing these recurrent implantation failure patients at our centers overall. And I believe that has given a lot of insight to all our participants on how to do the ERA test, when to do it, and how the protocol and biopsy should be done. Thank you so much. Thank you once again, iGenomics, for organizing this beautiful interactive webinar for us, and hope to interact and have these kind of very informative sessions in the future also. Thank you so much once again.
Okay. Thanks to you. Thanks to you.
Thanks, Dr. Moria. Thank you.
Okay, bye.
Okay.
Bye-bye.
Bye.
Bye.